I welcome you all to the National Symposium in Uveitis, and it's a 1.5 hour program.
Yes, sir.
Huh? 75 minutes
90
program,
minutes.
and we have got several speakers. I would like to invite Dr. Sudarshan from Shankarnetralaya, Chennai, to talk on genetics in uveitis. It's a new topic, a new area, and Dr. Sudarshan will enlighten us with the genetics in uveitis.
Good morning. I feel the same way how everybody feels for a Sunday, but then let's talk genes in uveitis. So practical considerations. I'm not trying to go into too much of theoretical stuff. It is not that we are all very aware of a lot of genetics in uveitis. That's the kind of upcoming things. So let's see. Sometimes you want to tell that there are no financiers itself, so where do you disclose any financiers? So uveitis has multiple etiologies causing multiple entities. You can have infective, non-infective, and there are some trauma and other things also. So we have many different groups of genetic associations with uveitis, like HLA association, the inherited ones, the inflammatory genes and other ones. So genes probably can be causative. They can probably have an association, whether it is the causative or not, we don't know. Sometimes it facilitates the process of the disease. So few of it we already know, few we are getting to know. So what we already know for decades is that HLA is the one that has been very well associated with uveitis. So HLA-B27 is the most popular one, and is strongly linked to the development of anti-uveitis. We know that it can be associated with Reuters, ankylosing spondylitis, inflammatory bowel disease, psoriatic. So all these HLA histocompatibility genes, which are associated with the inflammatory systemic diseases, can cause uveitis. So how is the frequency? About 50 to 90% of the patients with HLA-B27 positivity may develop uveitis. So the other strong association is about HLA-A29 with birdshot. Birdshot we don't have. Birdshot is not that common in India, but then there are other things like sarcoid which we actually see, where HLA-DR and other autoimmune diseases can be formed. The other scary one, other than HLA-B27, I'm always worried about is when you are waiting for a report to be positive, you are very happy sometimes that you made a great diagnosis, but then you don't want it to be positive because it's a very scary disease. Like severely vision threatening one, HLA-B51, the most scary one. So B51 positivity is not mandatory for diagnosis of Behçet's. So if you have a history of aphthous and genital ulcers, if you have some systemic thrombophlebitis, then you're probably dealing with a case of Behçet's. But then it's an important factor in determining the clinical phenotype. So there is something called epigenic interaction between B51 and the IRAP1. That explains the pathogenesis. So if you have suggestive clinical features, that is not mandatory, but if it is positive, then it's with clinical features, it is suggestive. So if there are suggestive clinical features, if you have a hypopyon panuveitis, you have ferning appearance, you have occlusive vasculitis, and you have systemic features with B51 positive, then you are definitely dealing with a case of Behçet's. So why you have to be so particular about Behçet's? Because Behçet's is probably primary indication of biological therapy. So if at all you are starting off biologicals initially in any disease in uveitis, probably Behçet's is one and GRA is another one. So you may sometimes have HLA-B51 positivity. I'm actually currently dealing with a patient of granulomatous anti-uveitis with CMV positive, which is B51 positive incidentally. They had tested it in US. So it is not necessary that sometimes you need to test based on the clinical features. So when you look at all this, we keep worrying about when to test for these inherited genes. If the gene is positive, is it specific for that disease? How are the chances of this disease occurrence? If the gene is positive but there is no disease, do we get a situation like that? Yes, we will get to it. There are some associated factors and then we'll look into it. So when to test for inherited genes? So obviously, if there is more than one family member affected by similar signs and symptoms, then you will definitely look for probably if something is happening in the family together. For example, this was one lady who had come with on and off steroid treatment, being treated as JRA, one-eyed, presented to us in 2017, and for the past 17-18 years she's on treatment with us, tried various combinations of medications, and finally currently she's stable on methotrexate and mycophenolate. She had a granulomatous panuveitis. She had this joint deformities and posterior segment lesions. Her son, a 3-year-old, was brought to us in 2014 with recurrent granulomatous uveitis. We again thought probably TB, intermediate uveitis, GRA. Also had some towed or dry skin, which was something suggestive. So, but now currently he is stable on tofa and methotrexate. Similarly, is the story with her another daughter who was ANA positive, which is misleading actually, and toxo IgG is raised. It is not relevant. So, if you don't have a clinical lesion, if you have toxo IgG raised or ANA, then you take it with a pinch of salt. So again followed up very well, stable on tofa and methotrexate. So this is a combination. You have a family of mother, son and daughter, all of them having similar granulomatous uveitis. So we tested for NOT2 mutation. When in 2013-14 we were not that aware of it. Now obviously we are aware, and we expect everyone to be aware of the fact that if you have a granulomatous uveitis, especially in a child, it is not JRA, look for BLO. So NOT2 mutation, if it is positive, there is something called familial BLO. So boggy arthritis, skin lesions and uveitis, it is a triad. Remember, it has to be granulomatous, and it can be misdiagnosed as TB sarcoid, and don't think it is JRA. So we reported the first familial BLO syndrome, and then we were wondering, if we found 3 of them in the family, are there many more in the family? Yes, there are many more in the family. Many were actually seen by my colleagues in the other room, and they were walking around, then we realized that they look similar, and probably we realized that they belong to the same family. So about 17-18 of the patients in the same family all have these clinical features, and we tested for NOT2 mutation. So among those family members who were all NOT2 mutation, all of them had clinical features, and all those who were negative with NOT2 did not have signs and symptoms. So it means that it is very specific gene. This is a family tree of them, and even the 4th generation, 1, 2, 3 and 4th generation, the 4-year-old kid is also affected now. So she is being treated with us now. So BLO is one thing. Again, I'm like blah-blahing about BLO. So BLO is very important actually. So it's not just about BLO among inherited ones. This is another thing. A young adult, she is about 18, 19 years old, and her younger brother. She had history of hair loss, early graying and hearing loss, had recurrent anterior uveitis. Her brother had like typical like GRA kind of presentation with BSK, chronic anterior uveitis. He also had hearing loss, but he also had history of pancreatitis. But he actually has dense hair, like no hair loss and graying. So this hearing loss and uveitis, we were thinking of one disease. Obviously, we all think of Cogan's. So you're wondering, but there are some disparities in this. Is there a genetic association with Cogan's? So again, they were treated with the combination of methotrexate, mycophenolate. This is how we go. We used to go initially, but now probably again, to repeat, biologicals is probably primary indication in patients with JRA. So undergo now stable on tofa and methotrexate. So we tested for genes, and then we found that there is a biallelic mutation in TKT in patients with Cogan syndrome. So this we have actually reported. Mutations in TKT gene was seen in the homozygous state in patients with in the boy and the affected sister. But the parents were heterozygous. They have a 3rd sibling who was a wild type homozygous variant, which was not associated with this. So it's important that it's so good that genome testing, that you know which gene and which kind of variant is there and which is related to the disease. Again, another one. A 5-year-old came to us about in 2015. She was stable for about 5 to 7 years. In December 2020, she had active inflammation and started the process of deteriorating. Vision started dropping. So luckily these parents were ready for adalimumab, and we started on adalimumab and methotrexate. But then 2 years back, they came with some kind of lesion like this. We were wondering whether it is flictin. So caution, in India especially, biologicals are very good, but then you always think of ruling out tuberculosis. So we thought whether it's flictin or not. We started on topicals, but then it watched and it got okay. And in about a year's time, everything was fine. When we did cataract surgery, she was doing well. So we thought like it's fine. We have gotten away with it. But then as always, it didn't end like this. In Jan 2025, she came back with granulomatous anterior uveitis. So we went through the whole process of blood testing, turned out to be negative. So I kept telling that granulomatous and uveitis, then it is BLO, but it may not be BLO also sometimes. TB it could be, then turned out to be negative. But then we had sent for whole genome sequencing, and then turned out to be RP1 gene positive. We are wondering like, how come RP1 gene positive in this? Did multiple tests, everything were normal. Then we were worried that are we dealing with combined diseases. But then the fact is that, like in any other lab test, sometimes better not to test for genomes which we don't suspect. If you are suspecting, they say like when you test for the lab test based on which you will treat. If you are not going to treat based on that, then you don't test for that. So if you are looking for NOT2, test for NOT2. Don't do the whole genome testing. Ask for specific ones whenever possible. So this is false positive. So you can have false positive also in gene testing, and also see how much of association is there with the genes with that variant. That is most important. Just because it is RP1, it doesn't mean that patient has RP. So you know all that, like not all HLA-B27 have uveitis, and we saw that all NOT2 mutations have disease. But why is that? There's something called monogenic and polygenic uveitis. The monogenic uveitis have mutations in a single gene, so the association is very strong, something like BLO or CARD15. In a polygenic one, the multiple genes contribute to susceptibility, like B27, B51. So in this situation, it may or may not be associated with disease, but in monogenic situations, it can be associated with the disease. The third group, the inflammatory ones, these are the current therapeutics are directed towards these, like the IL-23R, TNF-alpha, interleukin. So this we have a talk on biologicals, they'll be dealing with it in much more in detail. But then the TNF-alpha variations increases the susceptibility to uveitis in patients with inflammatory disease. Okay, I was talking about family, then one more family, last minute. A 9-year-old female with tofa and methotrexate stable had a recurrent intermediate uveitis, so started on tofa. A brother also had similar presentation. But then this kid had a granulomatous anti-uveitis, so again we went through the process, not too negative. But then ACTAP MTB was positive. So this gives us another lesson that if you have uveitis in the same family, needn't mean genetic always. Beware of common environmental exposure from the common gene pool. You need to understand that you can have a common gene pool, but in India you need to understand that you can have a common environmental exposure also. Her uncle or grandma who was living with them had a history of tuberculosis. So environmental factors and your genetically predisposed individuals have an interplay. Similar to what we saw in COVID, not all COVID vaccinated people were getting some disease. Some of them are having. We have this COVID vaccine associated VKH and so many things happening. There's one 60 plus old person getting VKH. So they've already studied and found that immune regulatory gene polymorphisms are in play. So we are talking about autoimmune, infective also. HLA association is known, but not that strongly. Innate immunity genes like toll-like receptors are known to have a thing. That is what is being studied now. But then, like my favorite always, obviously there is a strong association between immune recovery uveitis and HLA-B881 in patients with HIV. So patients with HLA-B27, B57, also associated with sweet syndrome, can have associated increased risk of infection in HIV patients. So it's important to be aware. We had a survey where all of us are part of it. We honestly rated ourselves and found that we were all poor in diagnosing monogenic uveitis specialists and rheumatologists, and the commonest monogenic uveitis which we were all ordering is not 2. So it can be probably genetic, or sometimes like people call it nepotic. So uveitis seems to be all about genes. So it's a crucial role. It plays identifying high risk in autoimmune associated uveitis. You can, in India, you need to rule out tuberculosis, otherwise not 2 is the happening thing. So early diagnosis and treatment is inherited things. So personalized medicine like adalimumab is very helpful. But more important one is like if somebody already has a monogene, like what you are going to do? You'll help. There is something called CRISPR gene editing, so which they target the gene itself to modify the gene so that the next generation doesn't get the diseases. Thank you. As being USA secretary, this is my role in inviting you all for the UCCon conference. You'll have great uveitic talks on 3rd, 4th, 5th and in Jammu. And Shankar Netralaya has a retina meet. Please come. Thank you.
Thank you, Dr. Sudarshan, for the excellent talk with good case examples on genetics and uveitis. Any questions to Dr. Sudarshan?
Yeah.
Yeah, Sudarshan, a really nice presentation.
Thanks.
Only thing when you show us the first pedigree, okay, it was a autosomal dominant. And next case, you did not show a pedigree, and consanguineous marriage was there, autosomal recessive. Now, if in uveitis practice, if we can do a pedigree, that's a very important, which I believe none of uveitis experts are doing, okay? Because if you can screen them autosomal dominant, autosomal recessive being worse in the condition and and runs in a very aggressive way, that will be very good. Now, thing is that for HLA-B51, okay, I'm a bit skeptical on one thing, okay. For Behçet's, it's not only HLA-B51, it's also B52.
Yeah.
Why it is important? Because Behçet's has a systemic vasculitis component also, okay, which can involve a neurological component also. So sometimes HLA-B51 one may be negative, but HLA-B52 may be positive. So I believe the two tests are also important for Basel disease.
Yeah, I totally agree. Like because whenever we ask for HLA B5, the Australia they seem to be doing a spectrum of it. So that's how we start getting this B5 and all. About the vasculitic component, that's what I was trying to mention. That if you have a thrombophlebitis, like that's one indication that the patient is towards Behçet's. If you have a systemic thrombophlebitis because of occlusive vasculitis or systemic vasculitis, then that's an indication for thing. And pedigree we've not been doing. This is because luckily many patients of the same family had this, so we started doing this. Otherwise, we don't seem to do, but which is a very good point that we'll have to be doing it. One point related to the pedigree or the aggressiveness which I want to add is that it is not always familial in the whole family trend. There can be sporadic mutation in a single person also. So maybe other patients in the family may not have anything, only one kid may have, that's a sporadic block.
Thank you, Dr. Sudarshan. Next, I invite Dr. Jyotirmay Biswas. Sir does not need introduction to us. Sir, heading the Uveitis and Ocular Pathology Services at Shankanetralaya, Chennai. Sir will be talking to us on challenges in pediatric uveitis. Over to you, sir.
Thank you, Padma, for kind introduction. I'll be talking on pediatric uveitis, a challenge. Pediatric uveitis is often a challenge. This is a group of uveitis if they develop vision problem that will be throughout their life. And this is the patients who do not complain of the uveitis. Often it is silent. And it's the parents who has to be careful to observe this uveitis and bring to the patients. Examining of the pediatric uveitis patients is also a challenge. Child may not be cooperative. You may need examination and anesthesia. You may coax the patients to cooperate. I have got a chocolate box in my drawer. Even if the patient is below 16, I give a chocolate, and that's how I prepare a rapport with them. So I'll be talking about pediatric uveitis, a challenge. Let me start with the case. I've taken permission for putting you the photograph to show this beautiful child. 8-year-old child, joint pain and swelling in the right knee. As you can see, the swelling is evident. No pain and redness in the eyes, referred by a rheumatologist. And when you looked at the patient's eyes, I found there's already synechiae, complicated cataract, and band-shaped keratopathy. It was a juvenile idiopathic arthritis associated uveitis, and juvenile idiopathic arthritis associated uveitis is the most common childhood rheumatic disease, and is the most prevalent systemic disorder in children with uveitis. JA associated uveitis can be pauci-articular, most common, knee joint commonly involved. Chronologically, if uveitis precedes arthritis, then it has got an aggressive course. It can have myriads of complications. Common is that band-shaped keratopathy, chronic anterior uveitis, complicated cataract, glaucoma, vitritis, CME, disc edema, and hypertonic maculopathy, and ultimately phthisis bulbi that can also see. The picture showing a band-shaped keratopathy in a patient of juvenile idiopathic arthritis associated uveitis, and here there is a cystoid macular edema. Juvenile idiopathic arthritis can produce 15% blindness of the affected eyes despite intensive treatment even today. How it presents, the peak incidence of JIO is at the preschool stage, and girls are 3 times more often than the affected than boys. In most cases, uveitis is non-granulomatous, but granulomatous uveitis, broad posterior synechiae have also been reported sometimes. The most common extra-articular features of JIA is uveitis. It develops in approximately 11 to 13% of all JIA subtypes, and in all patients with oligoarthritis less than 4 joints involved, the risk incidence increases to 41%. We have to tell that rheumatologists that the children with arthritis should have always an ophthalmic examination. 58% of these eyes had a final vision of 20 by 200, that is a 660 or worse, compared to the 3% who has got just Player's cells. Development of glaucoma, cataract requiring surgery, presence of cystoid macular edema, recurrent episodes of ocular hypertony leading to often blindness due to the phthisis bulbi. Hypotony. Hypotony is more common in JIA than any other form of uveitis. because there is a chronic inflammation and damage to the secretory ciliary epithelium. Male gender was found to be an independent risk factor in some study on the development of blindness. The first treatment option is the topical steroids with or without short-acting mydriatics, but the topical steroid you should not use for a very long time. They develop cataract, and you should switch over to the non-steroidal anti-inflammatory agents. Put the patients on methotrexate or biological. 97% of the uveitis specialists are of the opinion that there is an indication for systemic immunosuppressive medication with methotrexate as the first choice. Use of methotrexate in juvenile idiopathic arthritis has been found to be very efficient and tolerable drug in children with GIA. Now biologics have come. 73% of the pediatric uveitis specialists favors additional treatment with TNF-alpha inhibitor, adalimumab or infliximab. Adalimumab is the most preferred choice. And this is an elegant study by Professor Ramanan, adalimumab plus methotrexate for uveitis in juvenile idiopathic arthritis. So what are the surgical procedures sometimes required? This indicates lensectomy, vitrectomy, phaco with IOL is a controversial. With the biologics nowadays you can give it, take the chance. But lensectomy, vitrectomy has found to be better visual and long-term prognosis. EDTA chelation for band keratopathy, pancreatic keratoplasty when the cornea is very severely damaged, and trabeculectomy in glaucoma. Uveitis and rheumatologists needs to work in collaboration in this type of the uveitis. I wanted to show you another case, a 16-year-old boy, recurrent attack of pain, redness and blurring of vision, history of recurrent fever with systemic hypertension. In the 16-year-old boy, renal biopsy showed acute interstitial nephritis, urinary beta-2 microglobulin was elevated. And this was the kidney biopsy showing acute interstitial nephritis. And this patient had non-granulomatous anti-uveitis both eyes, resolved with topical steroid, oral mycophenolate and prednisolone. This is what tubular interstitial nephritis associated uveitis TINU. Here uveitis specialist and pediatric nephrologist jointly manage the patient. This is an 8-year-old male child, sudden onset of pain, redness and dimness of vision both eyes for 1 week, and this patient have granulomatous anterior uveitis with Busch's nodule. In addition, the patient had arthritis involving interpharyngeal joints and maculopapular dermal rash. And this is a 2-year follow-up after treatment with injection adalimumab and cataract surgery. Patient regained the vision. And this is a case which Sudarshan has talked about it. We published uveitis and sporadic blow syndrome, long-term follow-up on refractory case, treated successfully with adalimumab. Uveitis specialist worked with a dermatologist in this case. Intermediate uveitis in children is another disease which needs to be treated with caution. It's a severe disease with poor prognosis. Band keratopathy mimics GIA-associated uveitis, have an aggressive course in comparison to the adults. And they have got snowball exudates as seen in this picture or snow banking. Highest risk of development of complications. They develop cataract, secondary glaucoma, and even vitreous hemorrhage from the neovascularization of the periphery. Now need to rule out systemic disease, especially TB and sarcoidosis. Uveitis specialists need to work with internists in this type of cases. Now coming to the infectious uveitis, an infectious cause is responsible to 6 to 33% of all cases of pediatric uveitis. This could be toxoplasma, toxocara, TB, rubella. Congenital toxoplasmic retinochoroiditis we are seeing less and less nowadays. Nothing much you can do in this case. But in case of acquired toxoplasmic retinochoroiditis, intensive treatment with antibacterial like tablet Bactrim DS and application of the prednisolone tablet can reduce the visual morbidity. Toxocariasis should not be overlooked, and this is a posterior pole granuloma, peripheral granuloma, and chronic non-endophthalmitis like picture they can present, and this is a posterior pole granuloma due to toxocariasis. They have got some kind of inflammatory tissues attached to it, and this is a membranes attached to it, and this is a peripheral toxocara granuloma as seen in this picture. Tubercular choroidal granuloma can also be present, and this is a little bit rare. the before treatment of a tubercular choroidal granuloma and after treatment with ADT and steroids. Rubella retinopathy is also another condition. There is no anti-rubella medication, nothing much you can do. This patient with a salt and pepper type of fundus. Uveitis specialists need to work with an infectious disease specialist. And this is a case which I wanted to show you multimodal imaging in a case of bilateral frosted bronchitis in a 5-year-old boy secondary to the Epstein-Barr virus infection. This boy had sudden loss of vision in both eyes for 11 days, fever with maculopapular rash over the thigh and buttock. Vision was 3/60 in both eyes. What the patient have is frosted bronchitis. Both eyes are optos images showed characteristic frosted bronchitis. Anti-Epstein virus was very high, 400 to 420 international unit per ml. Anti-rubella was elevated, and patient was treated with the IVMP 250 mg per day for 3 consecutive days, followed by oral prednisolone 20 mg per day, and also antiviral tablet was given, though it's not very specific. And what happened? The vision improved to 6/5 and 6 in both eyes. Decline in the anti-BB titer to 225 international unit. The fundus shows resolution of retinal vasculitis. Last but not the least, this is an 8-year-old girl, no pain, redness, white hypopyon, not responding to topical steroid. Basophilic cohesive cells with hyperchromatic nuclei and scanty cytoplasm was seen from the AC tap fluid. And it was a retinoblastoma. We need to work with an ocular oncologist in this condition. Ocular relapse of acute lymphatic leukemia, lymphoblastic leukemia can occur. This is a 7-year-old girl who had a complaint of blurring of vision for 2 months. She had undergone chemotherapy 2 years ago for acute lymphoblastic leukemia and was currently on the maintenance therapy. And you can see the convex hypopyon infiltrates in the iris, the bumpy iris surface with infiltrate on the surface of iris. Here also IC tap showed acute lymphoblast. So we refer the child back to the treating oncologist for the bone marrow aspiration and CSF analysis and treatment in the form of chemotherapy and radiotherapy for the management of the relapse. The child was lost to follow-up and later came to know by telephone call that the mother, that the child has unfortunately expired. So what is required is a teamwork in managing pediatric uveitis, which is often a challenge. So rheumatologists, infectious disease specialists, nephrologists, dermatologists come into the picture in managing such patients. But if you need to work properly and if you can put your heart and soul in managing pediatric uveitis, it can be gratifying. This is a drawing made by one of my patients, a child about 13 years who had a VKH, and he is the child who brought this picture of mine in the OPD when he got back the vision. Thank you very much.
Thank you so much for the excellent presentation, sir.
Thank you.
Yes, coming to the systemic steroid use in children, what advice would you like to give it?
I think is that a few weeks is okay, but prolonged use of systemic steroid you all should always try to avoid because there is a chance of growth retardation. So I always put the patients along with the immunosuppressive agents and take up the steroid as soon as possible. Even topical steroids in the children, they can develop cataract.
Thank you, sir. Next, I invite the next speaker, Dr. Manisha Agarwal. She'll be talking to us on serological biomarkers in uveitis. Over to Dr. Manisha.
So good morning, everyone, and it's very overwhelming to see so many people sitting in the audience at the fag end of the conference. So in the coming few minutes, I would be speaking on serological biomarkers in uveitis. And uveitis is basically an ocular condition where a single disease can actually present with a whole gamut of presentations. A single presentation can be in varied diseases, and thus a clinical diagnosis may be a challenge for any clinician. 70% of the patients, a diagnosis can be reached with a proper systemic and an ocular history and examination, and we cannot really overemphasize on this. However, laboratory support is crucial for confirming this clinical diagnosis, what you've made in your clinic. The laboratory diagnosis includes direct and indirect tests both. The direct tests such as the smear, culture and molecular diagnostics, while the indirect tests are the immunological tests. So there is a whole battery of immunological tests that are available in uveitis, and this is just a list enumerating those. But I would be touching upon the more common ones which we often advise to our patients, such as the IGRA test for tuberculosis. So it is basically a measurement of the interferon gamma release after in vitro stimulation of T lymphocytes with MTB antigens. It's a more specific test for MTB indicating infection or a previous exposure. It quantifies the severity of infection. Higher the microbial load, higher is the T cell sensitization, producing the high INF alpha levels. It's not really influenced by the prior BCG vaccination or exposure to the atypical mycobacterium. IGRA has reduced sensitivity in immunocompromised patients, and it can be used in diagnosing latent TB in low endemic areas, and its specificity is about 92 to 97%. We have various kinds of tests which are available. However, it's important for us to know the differences between a Mantoux and an IGRA test. And these are the various differences between the two tests. A Mantoux test sometimes can be very harmful if you are going to be giving it a lot of relevance without really checking out how the test has been performed. So it is very important to also check out on the methodology of the test that has been done to really rely upon the results. So this is one of our one of our patients, a 45-year-old young gentleman on antiviral therapy when he presented with sudden diminution of vision for last 15 days. He had a history of cough with expectoration. You find that there is an extensive amount of vasculitis with a lot of retinal hemorrhages present in both the eyes. The vision in the right eye is quite poor. So where the clinicians actually went wrong was that if you see the viral titers, the serum titers are pretty high, and that is probably the thing which has led to a misdiagnosis of this particular patient. We repeated a Mantoux test for this patient. It came out to be grossly positive. We did the IGRA. Again, it came out to be positive. We did a CECT of the chest, and it was suggestive of multiple non-necrotic, non-calcified mediastinal lymph nodes, and there was a small subpleural nodule in the right upper lobe. We did an EUS FNAC, and it was suggestive of a granulomatous lymphadenitis. And what we did was that we actually stopped the antivirals for this patient, started him on ATT and oral steroids. And this is the timeline of the patient where you see there's a beautiful regression of that extensive, dangerous looking vasculitis in both the eyes, and also leading to a venous occlusion in the left eye. And you find that there is a gross visual improvement in both the eyes. We actually published this particular case as tubercular retinal vasculitis mimicking frosted branch angiitis, and this was actually a learning for us, that don't get carried away if your patient is presenting with high serum titers, is already on a particular treatment. You still need to revise the diagnosis. Coming to VDRL and RPR, I think this is really gaining a relevance in today's time, because we know that syphilis is very much on the rise. But what is important for us to know is that the seroconversion usually occurs about 21 days of exposure till about 6 weeks after the infection. So if the report comes out initially negative, don't think that the patient is not having syphilis if your clinical manifestations are fitting into the picture of a syphilis. So this is something to be kept in mind, and therefore it's required that you repeat the test again, and a 4-fold increase in the antibody titer will indicate an infection, a reinfection, or a treatment failure, and a 4-fold reduction in antibody titer is going to suggest a response to the treatment. The limitations, of course, being a reduced sensitivity in primary, latent and tertiary syphilis, and you can always have a false positive and a false negative result. We do have treponemal tests, the TPHA, which are thought to be confirmatory, and it is basically a microheme agglutination assay for IgG and IgM antibodies. The test is reported as reactive if the agglutination occurs in a dilution of 1:80 or more, and is usually seen in the 4th to 5th week of infection. So this is actually mandatory in today's time. We are just not doing VDRL, but we are advising a TPHA, and that is actually going to be confirmatory whether the patient is having a syphilis or not. So this is one of my own patients, a 38-year-old young unmarried female patient who presented with pain, redness, diminution of vision in the left eye for last 5 days, and she had a poor vision of hand movements in the left eye. Keratic precipitates were there, a lot of anterior chamber reaction was there, and this is the clinical picture she was having. So she still maintained a good vision. She had this typical plaque in the right eye fundus, and she also had a very typical picture of a syphilis in the left eye. But if you've not seen a syphilis patient, then probably you can go a little haywire in your diagnosis. And you also see these typical pinpoint retinal precipitates, which again are very classically described for a syphilis. We advised her investigations, but she was lost to follow-up for 3 weeks. She went somewhere else. She underwent this whole battery of investigations, and again the viral titers, they came out to be high, and the patient was actually treated as viral retinitis. She was started on valcyclovir and oral steroids, and she came back to us when she started dropping vision in the right eye. So from 6.6, she had become 6.36 now in the right eye, and that's the time after having undergone a treatment with antivirals, she thought something is not working. So she came back to us, and we did an OCT. Again, these typical intraretinal superficial precipitates were there. We investigated her further. The HIV was reactive. Her CD4 counts were low. The VDRL and TPHA both were reactive. She was started on heart therapy along with specific benzathine penicillin for syphilis, and she responded quite well. CSF analysis, of course, was done for neurosyphilis, and this is how she recovered. So at least we were able to salvage the vision in the right eye, which recovered to a level of 612 N6. However, the left eye, because of a delay of a proper treatment, optic atrophy had already set in. There was a lot of sclerosis of vessels, and we could really not salvage the eye. So what went wrong in this particular patient was she was a young, unmarried female, and the history that was being given by the patient, the initial clinician did not think of syphilis. Then she gets lost. She goes somewhere else. The serum titers of the viral pathology comes out very grossly positive. So she starts being treated with antivirals. And now by the time she comes back to us, if you retrospectively think, the clinical picture was very classical of a syphilis, which actually was not picked up by the other clinicians. Now coming to Weil-Felix test, we all know this is a test for the rickettsial diseases, and this is again one of my patients who presented with this clinical picture, a 66-year-old female patient with sudden painless diminution of vision for last 10 days with a history of fever, myalgia and cystitis. And this is the picture of the right eye, where you see there's a gross thickening of the macular retina. You also have a neurosensory detachment. And this is the left eye, where you have lesions which are basically retinitis lesions resembling cotton wool spots with lot of hemorrhages in the macular area and quite a significant drop of vision. So here we actually investigated this patient. Her dengue was negative. We advised her a Weil-Felix test, which came out to be strongly positive. So she was diagnosed to have a fever, which was secondary to a rickettsial underlying cause, and she was indeed treated with doxycycline and with oral steroids, and this is the kind of response we got in the right eye, where she actually had a regression of all those lesions with a recovery of vision to 6.6 N6. So this is how the patient has responded, and even in the left eye she's had quite a significant improvement of vision while being on oral steroids and on doxycycline. So 6 months follow-up we have of this patient, and she's recovered a vision of 6.6 N6 in the right eye and 6.12 N8 in the left eye. Toxo, again, it is a clinical diagnosis. We really don't need any kind of a serological test. But if you are in a confusion or the patient is having an atypical presentation like you are having it over here, then probably you need to support your clinical diagnosis with some element of a laboratory test. Can I just take a minute more? Thank you. Now coming to non-infectious uveitis, we have these tests such as the ANA testing. It is a standard method and it is used as a first step screening test for any autoimmune disease. I won't go through this busy slide, but we have to know that what is the relevance, what are the pros and cons of all these tests. But in current times, we are also doing the rheumatoid factor, the anti-CCCP testing, which are all the tests which are being done for non-infectious uveitis. HLA-B27 and HLA-B51, we have to take it with a pinch of salt. B51 is associated with Behçet's disease, but HLA-B51 positivity has not been included as a diagnostic criteria in any of the diagnostic or classification criteria for Behçet's disease. So you really cannot base the diagnosis of Behçet's just on the plus or minus of a B51. So to conclude, majority of the uveitis patients are primarily diagnosed on a thorough clinical examination. History is extremely important. The serology just helps you to confirm what clinical diagnosis you have made, and the serology also helps you to monitor the progression of the disease and the response to the treatment that you are giving. But please do not consider them as the first line of diagnosis for any of your uveitis patients. So thank you so much for your patient listening.
Thank you, Manisha, for the wonderful presentation. Any questions from the audience? I have got one question. I often face patients whom I suspect tubercular uveitis, and when I ask for the laboratory test, the patient says 5 years back I did the Mantoux test, but I don't remember what is the result. What do you do in this case? Do you repeat the Mantoux test, or you?
If my clinical suspicion is very high, sir, that I am indeed dealing with a tubercular uveitis, I would go ahead and probably not only repeat a Mantoux but also do an IGRA test. Thank you.
Thank you, Dr. Manisha, for an excellent talk. Next, I invite Dr. Padmamalini Mahendra Das. As we all know, she's an expert with vast knowledge of uveitis and has been the head of uveitis at Narayana Nethralaya, also the vice president of Uveitis Society of India. And also, while her talk is being put up, invite all of those to the Uveitis Society of India annual meeting, which is in Jammu this year on 3rd, 4th, 5th of October. So please join us in Jammu. And again, I thank the people who've bothered to come and attend this session. And I apologize to the speakers that there was a last minute change in the session. That's why Dr. Kalpana couldn't be here. Thanks to Dr. JB for filling in for Dr. Kalpana. And thanks to Sudarshan who changed his flight and he had to leave early. Over to you, Padma.
Thank you, Dr. Sushila. Very good morning to all of you. So, imaging biomarkers in uveitis, what is new? I do not have any financial disclosures. Coming to the recent advances in imaging, we can image from pole to pole, that is, studying the cornea to the retina. Cornea is done with confocal microscopy or anterior segment OCT. Iris, we do iris fluorescent angiography to map out the areas of ischemia. Anterior chamber, we can quantify the amount of cells present by the use of anterior segment OCT. Vitreous can be imaged with ultrawide field imaging, and also we can quantify the vitreous haze with the OCT. Moving on to the retina, we have multicolor imaging, ultra-wide field imaging, which includes both fundus photography, fundus fluorescent angiography, indocyanine green angiography, and ACTA. So all can be done with ultra-wide field. The next is FLIO. It is upcoming one, that is fluorescence lifetime imaging ophthalmoscopy. In the OCT, we have polarization sensitive optical coherence tomography, that is called PSOCT. It measures the functional ability of the thing. Whatever the anatomical we see is the OCT. PSOCT measures the functional. It measures the bifringence also, and the collagen mapping also can be done with that. Next is the Ocumet Biocon. Ocumet Biocon, it measures the mitochondrial activity present in the retina. It measures the flavoprotein fluorescence. Next comes choroidal imaging, where we have ultrawide field imaging, which can be done with ICGA and ACTA. Laser Doppler holography is upcoming to study the choroidal vasculature changes in retinal and uveitic conditions. Next, we'll move on to adaptive optics, which has been used earlier in astrophysics. Now it has been used to study the optic disc retinal changes, and it can count the cone photoreceptors in the retina. So these are the things various available in an armamentarium. I will move on to with the pearls. So whatever we have seen in a clinical practice or what we have reported. Recently, following fever, patients can present with in the form of retinitis. Whenever you see, this is a young child presented with cerebriform pattern of retinitis with perivascular clearing. This particular pattern is important. It's morphological to suspect mumps associated retinitis. Serological or molecular diagnostics can help us to confirm the diagnosis. So whenever OCT shows disorganization of the outer retinal layers with shrum-like material in the underneath the fovea. So whenever we see this kind of a pattern, we need to suspect mumps retinitis. It's another child who has again cerebriform pattern of retinitis. Here it's subtle, but whenever we see this morphology, we need to suspect mumps retinitis. So in addition to that, we also, when you do the systemic examination, they can have parotid gland enlargement, or if it's subtle, it can be picked up by the other radiological imaging such as MRI, which shows increased uptake in bilateral parotid gland in a case of a mumps retinitis. Following treatment with systemic steroids and hyperbaric oxygen, we could see the resolution with numerous scars in the retinal periphery. Whenever you see this kind of a scarring pattern, that again can give us a clue to suspect mumps, healed mumps retinitis. Next, we'll move on to another condition. We have dengue has various ocular manifestations. It can also present in the form of hemophagocytic lymphohistiocytosis, what is called HLH. Here is a patient following post-dengue fever presented with these presentations, that is cotton wool spots, retinal hemorrhages and peripheral subretinal whitish deposits. So these are the characteristic feature of HLH. Here when you do infrared autofluorescence, we could see the hyperreflectivity, this OCT corresponding to the areas of the cotton wool spot, whereas the peripheral whitish lesions are seen as focal aggregations in the RPE layers. So these again could be an imaging biomarker to suspect HLH. It can be due to any infections. We have seen it in dengue and also in post-COVID infections. Next comes post-fever retinitis. Many patients present with history of fever retinitis. We do not have morphological characterization to differentiate between either rickettsial, dengue or chikungunya or West Nile. But there are certain clues. Whenever we see a patient with ring retinitis, which we have seen in a case of rickettsial retinitis, this again could be a imaging biomarker to suspect post-fever retinitis. Multicolor imaging uses different wavelength to differentiate different activities in PFR. In multicolor, whenever you see a whitish, mainly on blue-green reflectance images in active ones, in completely healing ones, you can see the grayish or grayish-white during the resolution stages. ACTA also can help us to study the vasculature changes in post-fever retinitis, where we have done the quantitative and qualitative. We have noticed deep capillary plexus rarefaction is more compared to the superficial capillary plexus. The FAZ is distorted and irregular foveal network. ACTA is not useful, especially if there is a gross macular edema. Pearl number 4, we will move on to unilateral acute idiopathic maculopathy, what we call it as UAIM. Most of the times it is idiopathic and spontaneous resolution is there. Here is a case of a 13-year-old female presented with picture. On blood culture, she had Staphylococcus aureus infection. We have treated her with systemic antibiotic ciprofloxacin, following which there is resolutions. What is the imaging biomarker here? Coming to the OCT, there is SRM, like increased reflectivity with irregular margin, decreased choroidal transmission with the distortion of the outer retinal layers. When we see this kind of a picture, we have to suspect UAIM. This is a serial OCT showing progressive resolution of the UAIM changes on OCT. It took almost about 12 weeks for the complete resolution. ACTA shows enlargement of the foveal avascular zone in superficial and deep capillary fluxes with phlovoid areas in the retinal, outer retinal layer and choriocapillary layers. However, these changes are all reversed at 12 weeks. This is a polarization sensitive OCT, shows a pace retardation map shows the distortion of the thing at the ISOS junction. This is the normal eye and this is the affected eye. Ultra high resolution PS OCT thickness profile showed significant thinning in the nerve fiber layer in the affected eye compared to the fellow eye. Next, we'll move on to Pearl 5. Here again, the patient presented with history of fever with decreased vision. Fundus examination, we could see the hyperemia of the disc with focal areas of retinitis with multiple retinal hemorrhages looking like impending vascular occlusion. OCT shows hyperreflectivity of the outer plexiform and enleased layer and the outer nuclear layer, which ultimately lead to localized disruptions. Whenever we see this kind of a morphology on OCT, it's a foveolitis. We need to suspect dengue infection, and dengue serology was positive in this patient. FFA shows early hypofluorescence with late hypofluorescence. So following treatment with systemic steroids, we could see the resolving foveolitis in this patient. Next, Pearl number 6. Whenever we see a patient with herpes zoster ophthalmicus, we know that it causes scarring and anterior segment changes. But when we look into the posterior segment, we can show hypopigmented lesions in the choroid. They don't present at the time. They evolve over a period of time. ICG shows dark dots. OCT shows intraretinal cystic spaces with hyporefractive choroidal granuloma. Following antiviral therapy with systemic steroids, we could see the resolution of the granuloma. We labeled it as choroidal vitiligo following herpes zoster ophthalmicus infection. Next is Pearl number 7. Here is a 76-year male presented with pain and redness. Here in the history, he had recent travel to South America. That was a major clue in this case. He has been treated with repeated lung infections, skin infections with antibiotics and viral infection. This is a skin lesion photograph, and he had a pigmented KPs with posterior synechia with anterior segment reaction. Fundus, we could see a multifocal retinitis lesion in the right eye. There is a scars, and peripheral you notice there is an atrophic scars with few cotton wool spots. In this patient, because he gave history of South America, and when we did the confocal microscopy, we can see a cyst-like structure which is similar to histoplasma capsulatum. Based on that, we did the skin biopsy. The skin biopsy showed it is a case of histoplasma capsulatum. Following treatment with antifungal therapy, we could see the resolution of the imaging biomarker. What we saw as a histoplasma capsulatum on the corneal endothelium, this is completely resolved following treatment. The next is post-COVID retinopathy. Following COVID, they were giving steroids left and right, and we saw a lot of opportunistic infections, including this fungal infection.
Because time is up and we do have some more talks.
Sure.
So you can just wind
So
up.
I'll complete. Yeah. This is a rain cloud sign for suggestive of a candidal infections. This is resolved. Yeah. Can I complete with this? Yeah. Next is a paracentral acute middle maculopathy. Here the patients will complaining they have a blurring, they are not able to see, or they are seeing scotoma. The fundus is normal, autofluorescence is normal, FFA ICG is normal. Visual field shows defects. On OCT, we could see the focal areas of hyperreflectivity in the outer plexiform and the outer nuclear layer. Whenever we see this kind of a lesion, we have to suspect PAM. This patient was put on echosprin, following which we could see the resolution of the lesion and the disappearance of the patient's symptoms. So, various imaging modalities and the imaging biomarkers can help us to suspect what could be the probable cause. Based on that, we can make the tailor-make investigations. They help not only in making the diagnosis, but titrating the treatment in various uveitic entities. Thank you for your attention.
Thank you very much, Dr. Padmawali, for an amazing talk. Even I forgot the time is over because of such interesting cases that you shared with us. Thank you.
May I ask one question?
Yes, sir.
In case of dengue maculopathy, after the treatment, does it give a little residual scar or anything, or is completely resolved?
It depends upon the severity of the disease, but what we have seen is the dengue foveolitis, when they resolve, they do cause outer retinal changes.
Okay.
Next, I invite Dr. Balamurgan to give his talk on biologics and uveitis real-world experience. Dr. Bala is the head of uveitis service at Arvind Pondicherry. Can we have the presentation, please? No, sorry.
morning, one. Good morning, one and all. At the outset, I'd like to thank Dr. Somashila Madam and the AIOS for giving me this wonderful opportunity to present the real-world experience on biologicals in uveitis. There is no financial interest. When the term biological was introduced some 14-15 years back, I was thinking whether is it a weapon of mass destruction. So it can be used for constructive purpose as well. So we know there are n number of biologicals and the mechanism of
Can
action
you
as
increase the mic volume, or Bala, can you speak close into the mic? Then it won't be recorded well otherwise. Thank you.
there are n number of biologicals outlined in this cartoon, and the newer biologicals specifically target the immune effector cells, and they are so specific in the disease activity. They help in preserving the visual function with minimal possible adverse effect. Let me start with a small case. It is 5 cases. All of them are non-infectious with a male-female ratio of 1:4. The very first one was a granulomatous polyangiitis, and this female child, 37-year-old, in 2011 presented with granulomatous uveitis with scleritis. The baseline workup was normal except for the raised ESR. We were thinking in terms of vaginous and started on oral and topical steroids. What really happened was in 2010 we started with methotrexate because the patient was not affordable, and then we supplemented with cyclophosphamide, the level 4 immunosuppressants, and when it was not working, we still changed the drug to cyclosporine. And we know that the specific treatment really matters. Level 4 also didn't work. Then we shifted to rituximab in 2016 when 2 doses were given, and following with the ocular inflammation was under control. Along with that, the methotrexate was supplemented for maintenance dose. Why did we start immunosuppressive along with biologicals? It is to prevent the drug-induced antibodies. The case 2 was a JRA-associated uveitis. This was a 6-year-old girl presented non-granulomatous uveitis, and oral and topical steroid and methotrexate was started. And since it was not going off, we changed to MMF 2 years later, and then we shifted to adalimumab because still inflammation was going on. We were not super clear how long adalimumab was sufficient. Then what we did was we stopped the drug and see, surprisingly to our surprise, adalimumab stopping did not cause any recurrence in this case, which is a real surprise for us. The case 3 was a pars planitis, and we had a very severe complicated cataract, and this 6-year-old child in 2014 presented with CME. The workup was negative. Methotrexate was started for a year, and in 2015 we started with infliximab supplementation. It was given once in 8 weeks. 2 infusions was given. There was no improvement, and we shifted gears to the adalimumab 3 doses in 2017. Following both the inflammation, the CME was brought under control. The case 4 was a 16-year-old female with recurrent conjunctival ulcer, was the initial presentation, and developed oral ulcers, genital ulcers. Working diagnosis was kept in base sets because there was a systemic thrombophlebitis like presentation. Oral steroid was initially started. Methotrexate was started again for the cost factor, and supplemented with IV cyclophosphamide. So in this case, in 2014, rituximab was started in consultation with the rheumatic colleagues, and later the drug was changed to adalimumab. Every 2 weeks there was a resolution of the systemic and ocular symptoms. My last case was ankylosing spondylitis. This was a non-granulomatous anterior uveitis. Oral steroid methotrexate was started, and later, since it was not getting under control, infliximab was given as infusion. And the rationale for selection of the medication in case 1, we know that rituximab is a specific drug which targets the B cells, and the CD20 in particular really works. And we know there are a lot of literature supporting that it is considered as a drug of choice even in cases refractory to the cyclophosphamide. In the case 2, adalimumab was chosen because there is a lot of literature support suggesting that it's a second-line drug after methotrexate management of JIA, and the same rate of efficacy as infliximab but longer remission. So there are a lot of studies in the recent days, Visual 1, 2, 3, 4, and Sycamore trial were all supporting the use of the drug. Why adalimumab in pars planitis? Because initially started in infliximab, there was a worsening, and we thought a change of the drug will really help the patient care. The adalimumab for Behçet's, we know that it's super clear with several case reports, and in the case 5, infliximab was chosen. It was a purely rheumatic call. The moral of the case series is we need to think beyond steroids and to beyond immunosuppressants. We can't stick to a single treatment strategy, and it's both a science and art for us. Life is not a bed of roses. My part B of the presentation starts now, that where I burned my fingers. A 21-year-old male with recurrent oral gelatin ulcers, B51 was positive, infliximab was started as first line, and woke up with TB was negative. And you know what really happened after that? There was a real flare-up. Even the X-ray could pick up a cavitatory lesion, which was confirmed with the CT scan, and we were forced to stop the drug and start on ATT. And the drug was stopped, and later, when the complete ATT course, we were lucky enough to start the patient again on a low dose steroids and supplemented immunosuppressants. This was again a 45-year-old lady with bilateral recurrent VKH, started on adalimumab. You have a beautiful image support here, and later the patient developed demyelination with periventricular plaques, and the biologicals was forced to be stopped. So this is again a moral of the story. We should be super careful with the demyelinating process operating on these biologicals. This was a 17-year-old male with JAA present with recurrent anterior fibrinous uveitis, started with remote colleagues with adalimumab. After 3 months, the patient developed congestive cardiac failure, and the physician was super smart to pick even with the ECG changes and confirmed with the echography, and the drug was stopped. I can never forget this case because this was a 10-year-old male who presented with sudden defective vision in both eyes, also with redness and pain. The vision was 6/36 in the right eye, left eye was finger counting close to the face. So we had such a posterior uveitis like presentation mimicking VKH, and of course the imaging support was there. We were working with the diagnosis of pan-uveitis, possible VKH, started oral steroids and added with methotrexate. Later, since it was not getting controlled, shifted to mycophenolate, was added along with that. What happened was the child developed steroid-induced glaucoma. After 8 months of systemic immunosuppression, there was persistent inflammation. We thought that in modern age, if I didn't start ADA, I am out of the game. So started that, and MMF was started. So the dosage was mentioned here. Methotrexate was reduced to 15 milligram, and it was going on well. But suddenly, one fine day, the patient came back to me with a granuloma in the anterior chamber. The fundus examination showed a small granuloma superior to the optic disc. And we thought that, are we dealing with adalimumab-induced sarcoidosis? The OCT was also supporting. There was a granuloma-like presentation. What did we do next? We ordered for a CT scan of the chest to rule out TB. Adalimumab was stopped. Oral steroid was stepped up to 15 milligram. Was increased along with the stepped up dose of methotrexate. Inflammation was got under control. After 8 months later, there was another recurrence. We were not clear what is really happening. We repeated the MAN 2, again it was 17 millimeters, and this was a fundus presentation. The granuloma was trying to reduce, and with this case, we were thinking in our mind, is TB and sarcoid a spectrum of the same disease? The child was started on ATT after burning your hands with multiple drugs. After 6 months of ATT, the child was again started on azathioprine. It's like a cycle coming back to the square one. Luckily, the final visual acuity was 6/6 in both the eyes, no active uveitis when I came back, when the child presented 1 week back. Red flags while using biologicals. Don't use etanercept in uveitis. Although it is a TNF-alpha blocker, this can potentially flare up uveitis. We are not supposed to use any TNF-alpha blocker because the rheumatic colleagues might think that it is a cheaper alternative. Don't harp on etanercept, but don't combine interleukins with immunosuppressives. Along with the TNF-alpha inhibitor, we also have interleukins as another arm, which we do not commonly consider in India, but in abroad, especially the European countries, the interleukins are getting popular. Like you combine TNF-alpha blockers with the immunosuppressants, We are not supposed to combine the interleukins with immunosuppressants. With that, I end my presentation. Thanks a lot.
Wonderful presentation, Bala. The second case has methotrexate for 10 years. Okay. Then you have shifted into adalimumab. Okay. Now, methotrexate itself can cause pallor of the disc, where we should be skeptical in long term. JB sir can put in the methotrexate induced optic neuropathy. Plus, you see, I have asked Dr. Ramanna also this question. Methotrexate has optic neuritis in long, and adalimumab also has a demyelinating effect that we have shown with the Dawson finger of multiple sclerosis. Now, this is one note we should be careful, okay? The methotrexate induced optic disc. If we see pallor of the disc, we should be cautious when continuing the methotrexate.
Thank you, sir. It was new for me to know that methotrexate can cause optic problems. Thank you so much.
Thank you, Dr. Bala, for the excellent presentation.
Thank you, ma'am.
Next, we move on to the next talk, that is Innovations in Surgical Management of Uveitis by Dr. Mudit Tyagi. Dr. Mudit is a uveitis and vitreoretinal consultant from LV Prasad, Hyderabad. Over to Dr. Mudit.
All right. Good morning, and first of all, let me thank Dr. Somshila and the scientific committee for having me here in this session. And so I will be talking about innovations in surgical management of uveitis and how surgery can help us and how it is evolving over a period of time in our managing of these cases. Now, essentially, if you look at vitreoretinal surgery and how it evolved, this was the first initial device which was used by Dr. Mackamer. But from that device till now, when we have got 27 gauge vitrectomy systems, which just essentially make an entry of 0.4 millimeter inside the eye. You have got vitrectomy systems with cut rates going up to as high as 20,000 cuts per minute. So what we are now seeing are less invasive, shorter operating time and a faster recovery for many of our patients, and that has broadened the horizons of VR surgery in a lot of these cases. So how can vitrectomy help us? Now, vitrectomy has always been there. It's not something which is new, but what is new is the improvement in the machines and the less invasiveness of the procedure. So now there have been multiple studies which have shown that vitrectomy can be used not only as a diagnostic tool, but also for removal of vitreous opacities and removal of inflammatory mediators, which is subsequently leading to a reduction in the need for systemic immunosuppression as well as in the reduction for the long-term usage of steroids, apart from helping us in taking care of the complications that happen in some of these uveitic entities, including macular edema, epiretinal membranes, and the detachments and hemorrhages that can sometimes happen in these eyes. So the way vitrectomy has improved, it's not, to be honest, an innovation, but essentially a significant improvement from the systems that we have earlier. So this study, which was done initially, showed that it helped in establishing a diagnosis, in reducing the need for drug therapy and reducing macular edema, apart from management of hypotony. Also, it now allows us to take samples which can be sent for cytology and for cytokine analysis, so that we can arrive at a diagnosis which becomes more important in cases of lymphoma and where we are suspecting other etiologies and where there are diagnostic dilemmas. So surgery also comes to our rescue when we need to arrive at some of the diagnoses in these dilemmas. But now let me show you one more innovation actually, which is changing the way we deal with some of our uveitic cases. So this was one patient which came with this dense complicated cataract, history of decreased vision in the eye since 5 years. Vision was PL plus and projection of rays in all 4 quadrants, low IOP, hypotony, and UBM and B scan did not show us anything significant. So this was case number 1. And this is case number 2, 19-year-old female with decreased vision again since 4 years. Again PL plus, PR plus 4, again an IOP which is low, hypotony, and again a UBM which was done did not show any extensive ciliary body membranes, nor did the ultrasound show us anything significant. So now how do you go around tackling these cases where there is absolutely no visualization of the posterior segment, where you do not know what is happening behind? And that is where this innovation has started becoming very important for us, which is endoscopy. Now the first endoscope was developed in 1934, but the modern endoscopes that we use have been there since 2011, though they have now in the last 4 or 5 years become much more popular and have become much more a part of our treatment and armamentarium. So this is the endoscopy system where you have got a fiber optic cable which has got a built-in camera which is there in the microprobe, with which you can visualize what you are seeing inside the eye. So this has also got an inbuilt laser, though we do not use the laser that much commonly, but the camera does allow us a significant visualization of what's happening inside the eye, and it helps us in assessing difficult to access sites including sulcus, sclerotomy sites, ciliary bodies, pars placcata. It also becomes useful in these cases of refractory glaucomas where you can use it for endoscopic endocytophotocoagulation. So this is how basically the system is. You're not looking inside the microscope, but you're looking at a TV screen, and let me show you how it helps us. So these were some of our cases. One of them, or two of them, are basically post-corneal interventions. But the reason I wanted you to show this image was essentially to realize how it helps us. So this was a case with an extensive corneal opacity. The B scan seemed to be normal. But when we went inside, what we found was an absolute complete optic atrophy with disc pale and with sclerosed vessels. So this was an eye where subsequently we ended up doing no intervention. Again, an eye with keratoprosthesis with a B scan showing a detached retina, but it just shows the detached retina. It does not show you the configuration of what is happening to the retina. And an endoscope allows us to visualize the fact that the entire retina was necrotic. The same holds true for this case where the B scan will show you a detachment, but when you go inside, you realize this is an inoperable case. So these are eyes where it is helping us in prognostication, in understanding what is happening inside the eye. Probably these are cases where you do need to now give up and realize that there is no further intervention which is going to help this eye. But then on the other hand, you have got eyes like this where you have again got no visualization. But when you do a diagnostic endoscopy, what you realize is that you have got a completely attached retina with a healthy disc. So these are eyes which are amenable to subsequent interventions. This is an eye where subsequently a graft was done, and this patient ended up actually having a visual acuity of 20/50 subsequently. So in eyes like this, in uveitic eyes, there are some of these cases where we have now started doing a diagnostic endoscopy initially to prognosticate before we decide to go ahead with any further intervention. So this is the other indication where now endoscopy has started becoming more and more important in our uveitic cases, which is to look at what's happening to the ciliary body. So in eyes which have got a persisting hypotony, where you have got the ciliary body membranes, now what we can also do is that we can go ahead and remove some of these ciliary body membranes, assess and what is happening to the ciliary body, and visualize these membranes and go and remove them either with the help of a cutter or with the help of a scissor. So this was another patient of ours with a hypotony maculopathy. You look at the B scan, again all of these choroidal folds over here, and a UBM does show us a few membranes, and what we did was in this case was that we went ahead, removed all of these membranes, and we essentially plicated and cut and tried to remove as much of those membranes with the help of our forceps. Ended up putting 5000 oil inside the eye, but the IOP has started improving and the patient is likely to do well in future. So now basically how does changes in VR surgery or in surgery help us? They are allowing us an early as less traumatic interventions. They are also allowing us with the help of an endoscopy to visualize things and features which were earlier not amenable to visualization with conventional viewing systems, and is also allowing us to take care of these peripheral membranes which can cause havoc in a lot of these uveitic eyes. Thank you so much. I would also just take 10 fleeting seconds to invite you to these two upcoming meetings. One, Dr. Sudarshan had already spoken about the UCCon meeting in Jammu in October, and the other meeting which is happening in LV Prasad Institute in May, which will have different sections and workshops on all of these things that I spoke about, including use of fibrin glue and endoscopy and laser workshops and different instruction courses. So please join us in both of these meetings. Thank you so much.
Thank you, Dr. Modi, for the excellent illustrative video talk with the surgical intervention. So yes, it's these cases is one prognosticate when you operate on this, when the presence of the media hairs. How do you follow up these patients post vitrectomy when there is no visualization?
So then so there are two ways. Essentially that's one of the biggest problems in these cases is how do you go around following them up. But once you have done a vitrectomy, you know what's happening inside the eye. Subsequently a B scan can still be used to follow these eyes up, but initially not. And for uveitic eyes, once you have done a lensectomy, remove those membranes, the visualization improves. Their endoscopy works more for helping us in taking care of those peripheral hypotonic membranes.
Thank you so much.
Thank you.
Yeah. Next talk is on challenges in ocular tuberculosis. What is new? I invite Dr. Reema Bansal from Advanced Eye Care Center, PGA. She'll be talking to us on this. Over to Dr. Reema.
We are in our last talk. We request Kerala Ophthalmology Society to give us little grace time because they're very gracious.
Very good morning to all of you, and thank you, Dr. Sobshina, for the National Symposium. So I'll be talking on challenges in ocular tuberculosis and what's new. We all know the challenges are clinical, diagnostic, and therapeutic. Coming to the clinical challenges so far. Oh, I'm so sorry.
Presentation.
It's not showing.
No,
Yes,
it's
now it has
down
come.
there.
I'm sorry. So, coming to the challenges in ocular TB, we know clinical, diagnostic, and therapeutic challenges are there. So, clinical challenges, so far we've been relying on these clinical signs to make a diagnosis of presumptive ocular TB. But recently, the COTS has very elegantly addressed these issues of clinical challenges. And one of the objectives of the COTS study was to understand how the experts diagnose and manage TB. And COTS has been able to get a consensus on many of these terms. So, coming to what's new in diagnostics for ocular TB, COTS has revised the nomenclature of ocular TB, also has given revisions about interpretation of signs and investigations of ocular TB. So, the major breakthrough of this work is shedding of the term associated. That is, now no longer tubercular associated uveitis is used. By consensus, it has been decided to use the term tubercular uveitis. Ocular TB is an umbrella term, so we were all confused about intraocular TB, ocular TB, tubercular uveitis. So the umbrella term is ocular TB, under which if you have intraocular, are you showing me time? Oh, should I go on? Okay. So if it's an intraocular inflammation, it's tubercular uveitis, and if it is involving the sclera, it's tubercular scleritis. So under tubercular uveitis, we have anterior, intermediate, posterior, pan uveitis, and retinal vasculitis. So TB choroiditis is a different umbrella term, likewise, like ocular TB, and it can involve serpiginous-like choroiditis, multifocal choroiditis, focal choroiditis, tuberculomas, tubercles, and subretinal abscess. So interpreting, it's very important to know how the interpretation of signs is done in ocular TB. So these are the various phenotypes where the definitions of the phenotypes are given by the COTS. And so this is, I think I'll not, I did plan to speak in details, but this is what the serpiginous-like choroiditis looks like. And then phenotypes similar to serpiginous but different, it's like idiopathic multifocal or resembling APMPP, but not the typical pseudopodic lesions of serpiginous-like choroiditis. Tuberculoma is yellow subretinal lesion with surrounding subretinal fluid, maybe single or few, but usually they are not in plenty. And the OCT shows massive elevation of the RPE along with subretinal fluid. FFA shows initial hypo and late hypofluorescence. And choroidal granuloma is now an incorrect term because granuloma is a histological term. So it's better to use tuberculoma. Subretinal abscess is a variant of tuberculoma where you have rapid necrosis and tissue destruction, often accompanied with retinal hemorrhages, and it's not a separate entity, it's an extension of tuberculoma. Choroidal tubercles are typically found in patients with disseminated or miliary TB, maybe single, maybe multiple, they may be unilateral or bilateral. They are very tiny, less than 0.5 disc diameter, may be healed or inactive, and this is a part of TB multifocal choroiditis. So this is just for the reference in case you need to read the article in detail. Retinal vasculitis in TB is periphlebitis or arthritis. It can be with or without an occlusive disease, and Eales disease should not be used interchangeably with tubercular retinal vasculitis. So coming to the diagnostic challenges, some of them have been covered in the morning by in Dr. Manisha's talk. So this is the following the CDC. These are the CDC guidelines for interpretation of the PPD test. So I'll just like to highlight the answer to Dr. JB's question about what if the Montauk has been done in the past and we don't have a report. So typically the peak effect is seen in 48 to 72 hours, and if you want to repeat, if the patient has missed and there's no reaction seen, you can repeat it within 7 days to avoid the booster effect. But if it is done in the past, and if it is more than, if you're repeating it now, If it is more than 10 and there is an increase by 6 millimeters than the previous test, then it is considered positive. So coming to both TST and IGRA, in uveitis, none is superior to the other. You can use either of them. Not really recommended to use both of them as initial screening tests. PCR, when to do? There are no clue when you have no clues, clinical or laboratory wise, or there is treatment failure, or you have a good expertise and the laboratory facility. So as per the report number 3 by the courts, PCR is not routinely done and it may not influence the management in real world scenario. What's new in treatment? This is the report 1 by the courts, and it has given various minimum parameters for considering when and when not to consider ATT with consensus. So this basically depends on the phenotype, on the endemicity of the area, and on the presence of the positivity of the immunological test with or without radiological test. So the report number 1 addresses TB choroiditis, report number 2 addresses tubercular anterior, intermediate or panuveitis and retinal vasculitis. This is the COTS calculator, which is derived from the COTS consensus calculator, and you can log into it to find out whether your patient merits an ATT or not. So coming to the newer treatment in ocular TB, there is a rise in the the use of anti-VEGF treatment intravitreal for tubercular granulomas, and combined with moxifloxacin therapy has been proposed by Dr. Manisha, and there are reports of endorsing this treatment with very favorable outcomes. So this is the a very latest article on the immune response in tubercular uveitis and its implications for treatment from ATT to host-directed therapies. We are moving in that direction, but we are very far from truly incorporating it into the clinics. New observations in ocular TB, just two slides on research. A very interesting article by Dr. Soumya and Dr. Narsingh Rao. Basically, they have elaborated on human and experimental studies, and they basically two fundamental mechanisms in ocular TB. One, there is an inflammatory response to the live or the replicating Mycobacterium tuberculosis in the eye, which is the direct mechanism, and the other is the indirect mechanism, which is immune-mediated ocular inflammation by the non-viable MTB or its components in the eye. So most of the clinical phenotypes of ocular TB have a combination of both, with one being predominant than the other in different phenotypes. So this is our own experience of the proteomic differential expression in the vitreous of patients of TB as compared to non-TB uveitis. So with this I stop and again welcome you all to the UCCON meeting in Jammu from 3rd to 5th October 2024. Thank you very much.
Thank you very much, Dr. Reema. I think this was a wonderful session. Very quickly, that even if you think that there aren't too many people in the audience, but all of these sessions are recorded, or each and every session, and it's put across throughout the year by the editor proceedings. And one very good thing about uveitis, all the uveitis talks, is that because on the YouTube channel, and I've been asking for the how many viewership, what's the viewership? So we outrun the viewership of even cataract and other sessions.
Wow.
So even if you didn't go through the details, but maybe you could have, because the students access these talks and they do, and it's great that we have such excellent speakers who have put together these talks. We have JB sir, and each and everyone is a speaker in their field who have put together these talks. Will be accessed by students throughout the year, and that has been the data. And we'll maybe discuss that in the UCCON meeting. I think the first people to thank here, apart from the speakers, are the Kerala Society for giving us this extra time. I apologize for that, and thank you to the audience who attended this session. And while we're handing over, I'll just request the speakers to come here for a photograph. Thank you very much.
Thank you.
Thank you.